Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. September is Atrial Fibrillation Awareness Month. Also known as AFib, this serious condition causes your heart to beat irregularly. Nearly 6 million people in the U.S. have AFib, and 1 in 4 adults over 40 are at risk of developing this cardiac disease. What causes AFib? Why are more younger people getting it? And how can you reset your heart rhythm if you have AFib? We'll answer those questions and more as we're talking with Dr. David Schwartzman, Director of Cardiac Electrophysiology at the WVU Heart and Vascular Institute. Welcome, Dr. Schwartzman, to Live Healthy West Virginia.
Thank you very much.
It's great to have you here. So I always like to start with the basics. So let's start with, what is atrial fibrillation?
Sure. So let's start with the heart itself and how it works. So the heart is a pump. Mm-hmm. And its job is to move blood around a series of pipes that we call the circulation. Blood being grocery delivery truck in one part of the circulation and trash pickup truck in another. Heart's job is to move the trucks. As a pump, it's set up sort of like your washing machine, which is another pump that moves fluid around in circles. As you know, your washing machine is driven by electricity. You plug it into the wall. Electricity flows from a power source over wires to the pump motor and makes it go. The heart is set up the same way electrically, has its own power source and health, which detects what's going on around you and adjusts the rate that the heart goes according to what it perceives the need to be. So slower when you're resting, faster when you're exerting yourself, but always within a narrow range. And then once it decides on that rate, it sends that instruction as electricity over wires to the pumping area of the heart, makes it go. Atrial fibrillation is a situation in which the wiring has become frayed to the point where short circuits develop that causes the heart to beat in an irregular and often more rapid than normal way. That's the core issue that is atrial fibrillation. Does that make sense?
It does. That's a great analogy. And now I will never do laundry again without thinking of AFib. So how serious is AFib? I mean, what can happen if it goes undiagnosed?
Sure. So atrial fibrillation can cause issues. In addition to symptoms which are downstream from the inefficiency that's associated with the rapid and or irregular heart beating. Beyond that, because of that rapid or irregular heart beating, blood flowing through the heart can flow inefficiently. Blood flowing through the heart likes to flow efficiently, sort of like water on the middle of a river. When the heart is beating irregularly, it can be forced into inefficient flow, more like water on the edges of a river, and that can predispose to clotting. Now, these clots can form and be silent, or they can travel and dissolve. On occasion, one stays whole and lands somewhere else. It can be anywhere, but we worry most about the brain because of the unique susceptibility of the brain to being denied blood flow. So when a clot travels from the heart due to fibrillation to the brain and blocks a blood vessel, that causes damage to the brain, something we call stroke. So there's a connection between atrial fibrillation and stroke. Atrial fibrillation, because again of that often rapid and irregular heart beating, can cause the pumping area of the heart to get tired, something we call heart failure. And so beyond the symptoms that it causes, it can cause the pumping area to tire, which may or may not be correlated with the symptoms that people have. So in addition to reducing how people feel, what we call quality of life, stroke and heart failure are things we worry about in patients with atrial fibrillation.
How much does having AFib raise your risk for stroke?
Well, it depends. To turns out that if you're 45 with no other medical issues and your heart beats irregularly in fibrillation, it's far less likely for blood flowing through the heart to clot than it is if you're 85. And so age, gender, other medical issues, they all collaborate in determining whether the atrial fibrillation is likely to cause this clotting phenomenon. Without the clotting phenomenon, there's no stroke phenomenon. So there's a range of risk, but to give you a sense of magnitude, at worst, we're looking at somewhere in the range of 5 to 7 out of 100 people per year. Those would be the highest risk individuals. Lowest risk individuals would be close to no additional risk relative to patients without atrial fibrillation in terms of stroke. Does that make sense?
It does. You're doing great. Thank you. So what are the symptoms of atrial fibrillation?
So they're devilishly nonspecific, which
they always are.
They always are. Well, the body has only certain ways to express itself. So classic symptoms would be what we call palpitation, which is a sense of skip beating or irregular beating, rapid beating, shortness of breath, particularly when exerting oneself, a general sense of low energy or fatigue, lightheadedness, chest discomfort. These are classic symptoms of atrial fibrillation, but a significant minority of patients with atrial fibrillation are unaware of it. And so it's stumbled upon for other reasons. Classics would be your primary care physician detects an irregular heartbeat during a routine office visit. You come in for elective hernia surgery and your EKG shows atrial fibrillation. Your worried child buys you an Apple Watch, and lo and behold, you put it on and it's telling you you're in atrial fibrillation. These are all common ways that atrial fibrillation gets diagnosed in people that don't seek medical attention for symptoms. And again, these symptoms are not specific, so I imagine on any given day of the week, your energy level is lower than on another day. So patients often don't surmise that there's an issue going on that needs to be remedied beyond a better night's sleep or less alcohol, et cetera, et cetera. So
what are the most common ways you treat atrial fibrillation?
So, when we deal with atrial fibrillation, we focus in on this stroke risk, we focus in on the heart failure risk, and we focus in on what we believe the impact of the fibrillation to be on quality of life. Although if you were to Google atrial fibrillation, you'd see a fairly consistent signal that patients with atrial fibrillation, all things equal, are more likely to die than patients without fibrillation. We've yet to develop convincing evidence that death is due to fibrillation as opposed to the company that the fibrillation keeps. And so we are less worried about this mortality risk than we are about these specific underpinnings. Again, quality of life as it pertains to fibrillation. And when I say that, I mean there are many patients in whom if you waved your magic wand and got rid of the fibrillation, they wouldn't feel much better. So part of the art of treating patients with atrial fibrillation is to get a sense of just what atrial fibrillation brings to the table.
How does it affect your quality of life?
Well, as I said, with these symptoms, can significantly reduce quality of life. And so if you're fatigued all the time, or short of breath when you're doing what you otherwise want to do, or feeling your heart racing so that you can't get to sleep at night, et cetera.
Okay.
So a number of different ways in which it might reduce quality of life. So we focus in on that. We focus in on the stroke risk and this heart failure risk. And I would be remiss not to mention that there is an emerging literature which would suggest that patients with atrial fibrillation experience cognitive decline at a faster rate than those without, all other things being equal. This literature is rather new, and we're reluctant to put it into the discussion algorithm, as it were. We're worried about it. It makes sense, but it also may simply be, again, not the fibrillation per se, but the company it keeps. So other medical problems like high blood pressure or diabetes, or lifestyle choices like sedentariness or poor diet that can be associated with atrial fibrillation, commonly is associated with atrial fibrillation. So, but just to put that out there. So in terms of deciding how to treat, we want to take this, we want to minimize the likelihood of stroke, and we want to improve quality of life to the extent that treating the fibrillation can improve quality of life. So there are two general ways that we treat fibrillation. The first way is to simply slow down the rate at which the heart is beating for those patients in which part of the fibrillation syndrome is beating rapidly.
How do you do that?
We have medicines and some non-medicine procedures that we use to achieve that. And the other way is to rectify the abnormal rhythm, put the patients back into the rhythm they were born into, which is something we call sinus rhythm, not something you need to remember.
Okay.
But so two general approaches beyond stroke prevention would be this control of the heart rate. We call this rate control, or restoration of your God-given rhythm, which we call rhythm control. For rate control, as I mentioned, that's largely medicines that we use. For rhythm control, two general categories of care. One is medicines. We have medicines intended to restore and maintain normal rhythm. And then a general rubric called ablation, which is a family of invasive procedures in which we work our way into the heart and silence or neutralize areas that cause the short circuiting that I mentioned before. I liken it to wrapping electrical tape around frayed wiring.
Fixing the circuits, kind of?
Yeah.
All right, well, that makes sense. Now, I understand a couple weeks ago that you, and part of the WVU Heart and Vascular Institute, you guys were the first in the state and region to use an artificial intelligence fingerprint technique to treat atrial fibrillation. Now, tell me what that is and why this is a big deal.
Well, we don't know that it's a big deal.
Oh, we don't know yet.
We don't.
Okay.
We're hopeful.
Okay.
And this is part of a process that we're living through now and contributing to, we hope, in which we're learning about this short-circuiting and how and where to wrap electrical tape. So this process called ablation, although it's been going on for several decades, is still largely guesswork. So what we've learned over the years is that in the region of the electrical system, part of the heart we call the atria or atriums, certain areas are consistently associated with atrial fibrillation. And so we've learned using a variety of technologies to silence those areas. We believe that, so that gets us pretty good results, but far from what you would want, or which would be, okay, I do one operative procedure and I have 100% success rate. We're not there.
Okay.
Among the patients in who don't respond to what we know now, we believe that other areas of the atria are misbehaving, but we can't see it. When we're talking about seeing, we're not talking about visual. We're talking about recording electrical signals from within the heart and trying to divine which ones are telling us this, I'm abnormal over here, I'm not abnormal over here. Our belief is that just like a fingerprint, people who develop atrial fibrillation and in whom these areas away from the frequently trodden path have issues, that they're unique to those patients. So in terms of location and multiplicity, et cetera, et cetera. So what we're trying to do with these newer technologies is to allow us to visualize, if you will, that fingerprint so that we can use our ablation technology to silence those areas. And presumably, if we silence all the relevant areas at a given patient, we get it closer to that 100% success goal. So this technology is an iteration of this as computing power and these terms that we throw around, such as machine learning or artificial intelligence, come into use in medicine. We're hoping to capture the power of large data sets in which machine learning excels in seeing patterns that are difficult to see with the human brain simply based on size and complexity. We're hoping to capture the technology as to figure out where these misbehaving sites are in any given patient and utilize them to target. So this technology that we're using now is sort of the first thrust across that line, and my expectation is that there'll be multiple technologies, and then each technology will become more and more sophisticated with time. And so it's a gradual march towards a goal of one procedure, complete success, but we're not there yet. So that's why this is of interest. Time will tell as to whether this technology in its current iteration will be useful. As I said, we're optimistic, but we don't know. My expectation is that the next 10 years, as computing power, real computing power makes its way into the day-to-day practice of medicine, that there'll be multiple iterations that will build on each other.
So you're using AI to personalize
Correct.
The treatment.
That's correct.
Of AFib.
That's correct.
And it sounds like we're heading in the right direction.
We hope.
We hope, right?
We hope.
All right. Marching on, right?
Yeah.
Who is most at risk of getting atrial fibrillation?
Yeah, so age is the principal driver.
Okay.
What I'm fond of telling my patients and myself is that there's a price to pay for wisdom. That's my story, and I'm sticking to it.
I like that story.
But at any age, other medical problems can make it more likely. So there's a genetic underpinning. We probably don't know much about it yet because our ability to discern gene structures, in particular diseases like atrial fibrillation, which are different than so-called single gene issues like, you're probably familiar from your high school genetics class about pink flower, red flower, white flower.
Yeah.
So these are single gene determined traits. We have those in medicine, but atrial fibrillation is not one of them. In fact, most diseases are what we call polygenic, which means multiple genes are contributing to place a patient at risk. How many genes? We don't know. We're just getting into the era now where we're comprehensively sequencing the gene structures of large numbers of patients, and so this will make itself more and more apparent with time. In the meantime, apart from the occasional family in whom you could pull out one or two genes in which And these families express themselves in that most patients develop atrial fibrillation at a young age. Again, those are quite unusual. What we're left with is a tendency for first-degree relatives to have fibrillation. So, yes, my mom had fibrillation, or my sister had fibrillation, et cetera, et cetera. So we know the genes are at play here in this polygenic pattern. We just are not very good at it yet, and there's not much we can do about it yet.
Sure.
And so there's a genetic underpinning, but as I mentioned, the primary driver is age. At any age, other diseases make atrial fibrillation more likely. So if you have high blood pressure, particularly if it's poorly treated, if you have diabetes, if you're significantly overweight.
These are all the things West Virginians are number one in.
Yeah.
It's not good.
If you have issues with sleep, there's a syndrome called sleep apnea, which you may have addressed in your show. These things are all associated with a higher risk of fibrillation. Whether treating them will reduce or prevent, et cetera, data gets somewhat murky, but we believe so. So yeah, age is the principal driver, and then all of these other issues adjust within the age group.
Well, I did read an article recently that says younger people are developing AFib at an earlier age, and that the number of people under 65 with AFib is on the rise. Now, what do you think that's about? Why do you think that is?
So if you go back to what I just told you about these elements of health, which are downstream from the way we're living our lives, in particular our food supply, then it would not surprise you that because these underpinning diseases are happening at earlier ages, we're seeing atrial fibrillation, which is downstream from them. And so it's a lovely, a lovely demonstration of the importance of public health, where our ability to take care of patients bleeds into the intricacies of public policy, government responsibility, personal responsibility. These are all very murky topics, but it's a lovely demonstration of how atrial fibrillation is downstream from other diseases, some diagnosed, some not. And so, just as you're probably aware of certain cancers becoming more common at earlier ages for similar reasons, likely, atrial fibrillation is also patterning in that direction.
Wow. We got a lot to worry about.
Right. As long as you're not reading the newspaper, atrial fibrillation is something to worry about.
Yes. Now, the WVU Heart and Vascular Institute has one of the nation's top AFib programs, the Center for Atrial Fibrillation. I know this is our high-tech table. What are some of the cutting-edge treatments for AFib offered at the WVU Heart and Vascular Institute?
Yeah, so, we're obviously interested in a holistic approach, and so people come to you to deal with atrial fibrillation, you're not going to ignore what lies beneath, whether in regard to the way the choices that they make, other diseases that may or may not be diagnosed, high blood pressure being common. So I think our the bedrock for us is a holistic approach as we assess this situation. And then we go down the road of, as I mentioned, trying like heck to prevent stroke, and trying to make people's lives better vis-a-vis dealing with the atrial fibrillation, whether it's simply controlling the rate or putting them back into normal rhythm. We have the fingerprint technology is emblematic of a family of therapies and practitioners that do different things towards these issues. So whether it be restoring and maintaining normal rhythm, as I mentioned, that's ablation. Within that rubric is a family of therapies, some of which are done by electricians such as myself, others that are done by more traditional cardiac surgeons. The differentiator there is that we tend to operate through little wires that are thread into the heart through blood vessels, typically in the legs. Traditional surgeons will go directly at the heart, coming between the ribs, for example. Mm-hmm. And so multiple operators within that rubric, other operators involved in the effort at stroke prevention. And so it's a family of clinicians building up from that bedrock of holistic approach towards specific therapies based on patient needs.
Well, along the same lines, can you talk a little bit about the level of expertise of the team?
Yeah, we've been at this for a long time. So, we've written extensively about it, and you have, people who've been in this field as it has developed over the past several decades. It's a unique program in that you have a lot of experience in all aspects of care, whether it be this bedrock issue that I told you about, or the various techniques that we bring to bear to improve quality of life, prevent stroke, heart failure, et cetera, et cetera. So that's not common. Mm-hmm. Atrial fibrillation is so rapidly growing, and programs are hard-pressed to keep up with it in terms of having the resources to create a soup-to-nuts program, if you will. And many operators are young. It's only in the past 10 years that addressing atrial fibrillation with interventional procedures such as ablation has come into the mainstream, and so many programs are bringing on young people, which is a good thing, but experience matters, right? Mm-hmm. And then in certain areas, such as with our open surgeons, there are very few experienced programs nationwide. So the comprehensiveness of the staff in terms of experience and know-how is quite unique.
So we don't have to leave the state to get world-class care, that's for sure.
We don't believe so.
So do patients need a referral to be treated at the Center for Atrial Fibrillation?
No, not necessarily. They're welcome to call our frontline number and refer themselves. They often come by way of traditional referral paths, but with the growing democratization of diagnosis, such as that Apple Watch I told you about, which is one of multiple direct-to-consumer technologies, we see more and more patients who refer themselves. And so the answer is yes, they're welcome to refer themselves.
Okay.
So no prescription there.
All right. So before we go, I always like to ask, what's the most important thing you want people to know about atrial fibrillation?
It's a heart disorder that's worth knowing about and paying attention to. So, as I said, because of its link to a reduction in quality of life and its relationship to stroke. And so it's not something that should be ignored.
Okay, great. Well, thank you so much for sharing this information with us today.
My pleasure.
A lot of useful things to think about and start working on. Thank you so much.
Of course.
That brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information on atrial fibrillation, visit wvumedicine.org/AFib. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or on the all-new West Virginia Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Schwartzman and everyone at WVU Medicine, thanks for joining us.